Hello Malaysia, I'm Jared Ratnam and welcome to season 3.0 of Medical Today. Once again, we have a season filled with amazing doctors, subject matter experts coming on to teach us about enhancing our lives and improving our health at all times right here on Medical Today. This being episode 1 of season 3.0, we're going to start by talking about laser. Now, most of us know that, or most of us who've read about it, know that laser technology began as early as 1957, but there's an ongoing debate as to when it actually started. Now, if you're a big fan of the Big Bang Theory, you'd understand all these things. But if you're not, don't worry, do not fret, because we have in the house Shah Zarak Khan. He's the CEO of Photomedic Solution, Sendirian Berhad, joining us to talk a little bit about laser and how it has impacted the medical industry within Malaysia and also around the world. Shah, very good day to you, and thank you very much for taking time off to be with us. It's a very interesting first episode because straight off the bat, I see so many things on the table. We're going to get to that. But let's just start with Photomedic Solutions. What's that mean? Is there a meaning behind the name?
Yeah, hi Gerard. Thank you. Thank you for the invitations. All right, Photomedic Solutions, the name derived from the technology of light. Right, formerly it was known as triple L3, right, and class 4. But today, photobiomodulation is the scientific name, right, which is being applied for the studies of laser. So it derived from light. Mm-hmm. Right, so looking into the areas of light and with the implications to medical, so we put in together as photobiomodulation. That's right. Photomedic.
Right. Very interesting indeed. I'm sure it was quite a journey for you to bring this this solution or this technology into Malaysia.
Yes, it started about 15 years ago, right? But basically, how I started was actually accidental, mm-hmm. Right? Coming to it, which I'll share later, and there are a lot of rejections, mm-hmm. Right, from the very beginning. Right,
within the medical industry.
Within the medical industry, yeah. Right, thinking mm-hmm. that it is an alternative treatment, mm-hmm. but the fact is it's not.
Right. Right. So it's not an alternative treatment. It is now being used widely within medical circles in Malaysia, right?
Since 1960s.
Okay, let's go back to the history of laser. Yeah. I talked a little bit about the history. Tell me about the history of laser. From what I've read, I know the process of understanding lasers started in circa 1957. But there's a longer story to that. What is the story that you have for us?
Okay, firstly I will say that that year reminds me because we will be celebrating our Medica, mm-hmm. Right, yes. 31st August. Right. 1957 was where it was actually started off. It could be before that, right? But it was not basically announced. And once when it was discovered, they actually tested with ruby lights. Mm-hmm. Right? Those days you can get good genuine ruby lights.
You mean you're talking about actual rubies?
Actual rubies.
Right.
Yeah, they're not cheap. You know, mm-hmm. That's the one you get in your fingers. Mm-hmm. Right? And basically they tested out on the rat. Right? They actually put a disease into a rat and basically try to improve the immunity of the rat. Right? Some sort of a tumor base and so forth. What happened is that when they shaved that part of the hair of the rat, and coincidentally, they discovered that that part of area, actually, the hair grew much faster, right, when it was irradiated.
There is hope for me. So, okay, so after that, once they recognized this, what happened next?
Yeah, and from there, it was taken, hey, okay, something actually happened, and this is great. And ruby was basically visible with your eyes. It's red in color. And the wavelengths actually helps to improve, and they started testing out many other areas, right? Many other areas of medical sciences, right, which Asia actually got feedback much later, right? And as they go about it, and they found that they can actually apply it for currently what we talk about pain management.
But I guess the question here is that hospitals find it hard to warm up to lasers simply because a lot of studies are still being done. Of course, we have got a lot of promising results now, but having said that, a lot of people are under the impression that lasers aren't safe. Are they safe?
Okay. Well, I would say yes and no. You got your goggles on?
Goggles, yes, I do.
Right.
Okay.
Okay, let's put it on.
I'm going to put on my Elton John goggles, and I hope this is not spoiling whatever we have on TV right now.
Any guitar?
No, no guitar.
Right. Okay. So basically, its answer is yes and no. Right. The most important thing is that you should avoid lasers, right, from hitting your eye.
Okay.
Right. Whether accidentally or directly.
Right.
Right. Because it has got the radiations that can damage your retina. Right, if it's not careful.
Now, how does this pair of goggles help with what we're talking about?
Lasers comes in wide spectrum. Basically, you have got CO lasers, there's carbon dioxide lasers, you've got gas lasers, you have got kryptonite lasers, you have got different type of diode lasers, and they come in different characteristics.
Right.
Right. Characteristics means to say that it's just like human being. Everyone is different, right, in nature. So laser has got its own wavelengths. So
and
those
different applications.
And different applications. Right. Different sort of what you call it penetrations as well.
Right.
So when I said no, it's important that we avoid the eyes, and if we are treating someone, right, we have to ensure that the person is not pregnant.
Right.
So you don't treat in that particular area. Right. Other than that, it's quite safe.
Okay, we've come so far with lasers, or that's what we hear. We know so much about lasers today. It's being used within the medical fraternity. Now, what is it being used for? I hear that it's being used a lot for cauterizing tumors. Did I get the right word for that?
Well, I will say tumor destruction.
Tumor destruction.
Yes.
Okay. Okay. So
okay, but before coming to that answer, I just like to recap a few points here. Right. All lasers, they are not the same. Okay. Lasers is a big word in contrast with LED, light emitting diodes. A lot of manufacturers are claiming that the LEDs are like lasers diode.
It is not.
It is not.
So LED and lasers are two different things. LED is an acronym for light emitting diode. Yeah?
Yes. And the qualities of the lasers, although it can be from the same spectrums, the quality differs. Right. I've done a lot of tests for the past 15 years. You could be using a laser for a particular situation, right? But the output and the results are not the same. This is number two. Number three, that they have got different penetration depth. Okay. And number four is that I need to be emphasized on this, that lasers should not be subjected to tenders. Right. When the person buying it, right, when they think it's cheap, oh, I already got a cheap one. I've got a FDA cleared, which is different, than approved. All right. So it's very, very important to understand the grade and the quality of lasers. That's where we come into phase to basically share with the audience on that.
Right. Can I have a look at your goggles again, if you can take this out? So this is the pair of goggles that's used for actually deflecting lasers away from, or from not spoiling your eyes.
Well, deflecting is, I will not use the word deflecting, but it stops there. It stops.
It doesn't penetrate this goggles. So
it doesn't penetrate these goggles.
So these goggles are specially made. You can't just wear any goggles,
it's
right?
designed for specific wavelengths and the type of laser that you use.
Right, so we're talking about wavelengths here. Yes. Speaking of which, let's talk about pain management right now, and let's talk about all the treatments available for laser. Of course, this is more of an advertorial for you.
Okay. There are a wide spectrum of pain management right, in the industry. Just to cluster it into simple form, sports medicines.
Okay.
Right. You have got knee, back injuries due to sports. Right. ACL injuries. Right. Pre-surgeries and post-surgeries applications as well. You got sciatic, low back pains.
Right.
Arthritis of the knees. Right, frozen shoulders. Right, I understand you have a back pain.
Yeah, I do have a back pain. But thanks for telling the rest of the country and also the rest of the world. Okay.
Yeah, okay. Yeah. So I mean, back pain is a common problem, right? You know, lifestyles, right, that person has, and basically if you apply lasers on those areas of back pain, what it does is that it helps to, firstly, you need to identify whether it's acute or chronic, right? So you put them into a program. As you put them into a program, you could be able to study to see how effective the laser actually bring down the inflammation of the area.
Right.
Lasers works with the inflammations.
Right. So the work of the laser, when you talk about sciatica problems, is to the reduction of inflammation.
That's right. So we need to work from proximal to distal.
Right.
Identify the root cause of problem, and then you apply the lasers from there.
Right. Now, in terms of using it for urology, okay, are urologists in Malaysia happy with what a laser does?
Yes.
Yes and yes, or yes and no?
Well, I would say the old school of thought is that probably some of them will prefer surgical approach. Okay, but basically when you have lasers, you have less scars.
Right. So we now know that people don't have to undergo many surgeries because of the birth of laser in medicine. Yes. Right. Okay. And tell us a little bit more about that.
Okay. Just besides urologies, the areas that you actually apply are basically on gynecology. Right? Interesting though that today there are many doctors that, especially for treatment of SUI, right? The final treatment is just surgical, but today you can basically control that and reduce that, right, on mild and moderate applications, right? Other areas are basically in terms of cancer, right, where we use PDT, photodynamic therapy approach, right? You can basically destruct the tumor without killing the good cells.
Right. I also hear that for diabetics, they're using laser treatments for the healing of wounds, so on and so forth.
Well, that's the easiest and the simple process.
Yes.
Right. And I will say that it is one of the affordable process to be treated using lasers. And again, it goes back to the type and the correct wavelength that you use. It helps up to close the wounds. It produces nitric oxide.
Right.
It creates angiogenesis. You have more blood flow to the area. And if the wound is quite deep, what you need to do is just simple debriefments, right? And apply laser for about 2 or 3 minutes, right, in those respective areas. Patients heal very fast. Right? This is not what I say, but this is from the medical evidence that has been published in the Lancet. There are more than 1,000
So we're talking about published evidence.
Published evidence.
Well, Shah, we've got about 2 minutes left. You've got 2 contraptions in front of you. Would you like to walk us through what this is before we let you go?
What I'm showing you, we have around about 159 different tools, I would say, lasers. Right, this is just 2 of it, right, depending on the application of it. What you're seeing here, basically on your left, is basically a laser that's actually applied for, I call it a non-surgery approach. Right? It's a laser that actually goes into your sleep disc. It shrinks your sleep disc. Right. And patients can be done with daycare. Right? The only problem is that it's, I wouldn't say a problem, but basically the approach is that it's quite fast. You just need a daycare. Right. Patients come in today and they can actually go back tomorrow.
So that is used for back problems, yeah?
Back problems.
More so disc problems, yeah?
Yes. And it's portable, yeah?
Right.
Right. And another part, one over here, right, this is the latest aesthetic lasers. It used to be so big and so huge. And
now it's this small.
Now it's just small.
Wow.
You can put it in your pocket.
Yeah.
And take it back.
I should try putting it in my pocket. Okay. Yeah. Okay. It's not happening, but I'm sure we're going to get there. We just have to admit it.
That's right.
All right.
Right. So everything is becoming fine. Right. It's all about the grades, as what we have discussed earlier. Right. Right. The approach. We are making life much more easier, much more simpler. And the future is the laser.
The future is the laser. There you heard it right here on Medical Today. The future is laser. Joining me in the studio is Shah Zarak Khan, the CEO of Photomedic Solution, Sendirian Berhad. He's come in with all his laser contraptions. There are about 159 medical devices in the market at this point. Once again, thank you very much. We hope to have you back on the show again to talk about lasers.
Thank you.
In a future date. We really want to delve more into back problems. Yeah,
sure.
We'll see you soon. Thank you very much.
Can I have my goggles?
You will in a short while. Stay with us. We're going to take a short break, and when we come back, more for you on Medical Today, Season 3.0. I'm Jared Ratnam. Hello and welcome back to episode 1, season 3.0 of Medical Today. With me, Gerard Ratnam. From laser, we now move on to cardiology or to heart problems. Well, most of us don't know this, or most of us actually read about it all the time, but we don't know that heart problems or cardiovascular problems is one of the leading causes of death in Malaysia, one of the leading problems of health in our country. Now, a lot of conversations surround cardiovascular disease, and these conversations need to continue in order for us to get a better understanding of what it is and how we can change our lives to stay away from cardiovascular diseases. Now, joining me is Dr. Chee Kian. He's a consultant cardiologist from KPJ Tawakkal KL, or it's Tawakkal Specialist Hospital in Kuala Lumpur, joining me to talk about cardiovascular diseases and correctable problems. Doctor, thank you very much for taking time off to be with us. It's great to have you here on the show. Now, I'm going to get straight into it and ask you the principles which causes heart diseases. What are the principles or the underlying principles behind heart problems?
Thank you very much, Gerald. When we talk about heart disease, the main bulk of heart disease in the world today is actually coronary heart disease. So the principal or main causes of coronary heart disease are hypertension, diabetes mellitus, dyslipidemia or high cholesterol, smoking, obesity, physical inactivity, and of course the familial or genetic factors. These are the principal causes of coronary artery disease.
Right. When we talk about preventing cardiovascular diseases, you just mentioned hypertension, and this is something I've been reading a lot about as of late. Now, it's very easy for us to say, okay, to prevent hypertension, you need to do this, this, and this. But a lot of this goes back to stress at work, and a lot of us have to go to work. Now, this is one of the contributing factors or one of the major factors within hypertension in Malaysia. Of course, the bad diet is another thing altogether. But what are your thoughts on this?
Hypertension is generally a disease, a silent killer. All right, okay. I think it has got a lot of the thing to do. It's a multifactorial risk factor. It can be related to familial or our genetics. It also can be related to our lifestyle, our salt intake, our modern diet. So hypertension is one of the main causes of coronary artery disease, which we need to tackle to prevent coronary heart disease. As we tell all our general population of patients, we must know our number, which is the blood pressure number. What is an important number to remember? I think for all purpose and intent, for all ages, we try to tell everyone of our population that you must aim for a blood pressure of less than 140 by 90 millimeter mercury.
140 by 90. But saying if you have a risk of a heart problem or if you had an infarct before, that's still not ideal, isn't it? You need to bring it even lower.
Yes, generally there are two guidelines in the world today. If you take the European guideline, they will say that anything less than 140 or 90 millimeter mercury would be quite acceptable. The American guidelines have gone even lower, and the Americans say that you should actually aim for less than 130 by 80 millimeter mercury, because we must remember the risk is a continuum risk. It's not a number. It's not above 140 or 90 you're going to get more heart attack. It's actually a continuum. Your risk of getting a event, a cardiovascular event, increases every moment after 130 by 80 millimeter mercury. So it's a continuum risk rather than just a number.
But it's interesting that it has to come out from the mouth of a cardiologist rather than a primary healthcare physician, because hypertension starts from primary healthcare. Are we doing enough at primary healthcare to ensure that when by the time they get to you, they at least understand what systolic and diastolic is?
That's a very interesting question. I think what the cardiologists in this country or in the world are doing nowadays are actually to educate our primary health providers, our GPs, our family physicians on what is the blood pressure target that we are trying to aim for. I think at the end of the day, screening our population properly, make sure that they get the definition of hypertension is correct, make sure that they are being treated properly to bring it down to an ideal blood pressure of less than 140 or 90. And I think this has been what the National Heart Association of Malaysia, or the NGOs, National Foundation of Malaysia, all the hospitals are trying, Ministry of Health, are trying to educate the public as well as our primary health providers.
Now, if you look at the age or the median age of a person afflicted by heart disease or getting a heart attack, they're getting younger and younger. I think your youngest patient, correct me if I'm wrong, it was 19 years old?
Yes, yeah, as told to you just now in my conversation, my youngest patient who suffered actually a heart attack or acute myocardial infarction was 19 years old.
Acute myocardial infarction with destruction to anterior or posterior?
Yeah. Acute myocardial infarction in a layman's term is heart attack.
Heart attack.
When we talk about a patient who has suffered a heart attack, what it means is that there's
muscle damage,
death of a part or portion of the heart muscle due to inadequate blood supply. And as told just now, my youngest patient is actually who suffered a heart attack is a 19-year-old. He was a rugby player, and his risk factor was actually dyslipidemia, or very high cholesterol, as well as obesity. So it comes as no surprise that I think age is no more the so-called limiting thing that you will not get a coronary heart disease.
Right.
Because as you can see, coronary heart disease is a disease of the modern world, a disease of the 20th century. Hypertension, diabetes mellitus, which is actually the major coronary risk factor, as well as obesity, physical inactivity, and of course the one of the culprits which we really should actually stop is actually smoking.
Smoking, yeah. So I think when you talk about lifestyle changes, all of us talk about lifestyle changes, and the most of us in Malaysia are looking for that one pill that will cure all our problems. That's never going to happen. Lifestyle changes has to be made. And for those of us who smoke, I think the biggest thing is to give up smoking. There are many ways of doing that. There's cessation clinics also, a lot of them in public and private hospitals. So many things we can do. But when it comes to eating, this is a problem to us because we don't eat to live, we live to eat. That's the Malaysian way. Now, what would be your advice in ensuring that you're eating decent portions or decent meals on a daily basis? Of course, eating purely healthy food is very expensive. We can't do, some of us can't do that. But what would be your go-to standard advice be?
My standard advice for all my patients and also for the general public is that everything to be eat sensibly, eat moderately, okay? Cut down on your sugar intake. You have to cut down on your salt intake. We eat a lot outside, okay? So some of the things that is beyond our control. But when we are at home, okay, we should adopt all this healthy lifestyle, so-called cooking. This fast food,
is something you should stay away from.
We should try to reduce it, and also I think the important thing is actually the sugar and salt intake. All right. I think that is the two
sugar and salt intake.
Sugar and salt intake,
because that leads to
diabetes
and hypertension too.
Yeah, exactly.
Right. Yeah. Now I'm going to read out something to you. This was given to me by the producer. Our heart normally beats about 60 to 100 times each minute, but sometimes it is out of rhythm, which is irregular. What is the first thing we should do when irregular heartbeats or palpitations, or we do experience things like this?
It's very interesting. Palpitations is a very common symptom among patients that come to see the cardiologist. By definition, by strict medical definition, palpitation just means that awareness of one's own heartbeat. But to a patient, palpitations means they feel that their heartbeat is beating faster and irregular. Most of the time, the patient that comes to us with a so-called palpitations, they are found to have normal sinus rhythm or normal rhythm. But as with a person age, when the patient complains of irregular heartbeat, we have to really rule out a condition, an irregular heart rhythm condition called atrial fibrillation. Because atrial fibrillation predisposes to stroke or cerebral vascular accident. In the younger subset of patients, generally, patients who come in with a real awareness of a fast heartbeat and feel very unwell or giddiness, one of the arrhythmias or this abnormal rhythm situation that we need to rule out is a supraventricular tachycardia in the younger subset.
Supraventricular tachycardia.
Yeah. There's a abnormal accessory pathway in their heart conduction system. So these are the two main things that we have to rule out, an atrial fibrillation as well as a supraventricular tachycardia. Now, of course, they are all more dangerous rhythm, okay? The ventricular arrhythmias and so-called and so forth. But generally, the patient who is well enough to come to see you, who complain of irregular heartbeat, atrial fibrillation should be ruled out. All right.
Now, here's a very interesting question. What is the difference between between heart disease, a heart attack, and heart failure?
That's a very interesting question. When we talk about heart disease generally categorized into a few major entities. The majority of them is actually coronary heart disease. The other entity of heart disease are the cardiomyopathy, diseases of the heart muscle, weakening of the heart muscle, which can be due to a lot of factors. Again, coronary heart disease being the major cause, besides virus infection, substance abuse, so on and so forth. Now, the third heart disease entity is arrhythmia, like the irregular of heart rhythm. Arrhythmia is one big heart disease entity that we deal with. Okay, the other one is of course the valvular heart disease or congenital heart disease, the hole in the heart. That's another entity. All right. Now, when we talk about heart attack, we are talking about acute myocardial infarction. That means there's a death of a portion of the heart muscle due to inadequate blood supply. The third one is of course the heart failure. When heart failure is actually an entity whereby the heart, the left ventricle, failed in its capability to pump blood out, and this leads to heart failure. Heart failure can be due to a lot of causes as well.
Right, that's a very interesting explanation. But here's another thing. A lot of people talk about a cramp in the heart. Does that actually happen?
Now, this so-called term of heart cramps is actually a layman term for a cardiologist. Is actually a coronary artery vasospasm, a sudden constriction of the coronary arteries, the arteries that supply blood to our heart muscle.
Right. How dangerous is this?
It's actually most of the coronary artery vasospasm are actually due to atherosclerotic, pre-existing atherosclerotic disease as well. But there are also certain entity or certain condition whereby the heart, the coronary artery constrict on itself with no evidence of blockage, no atherosclerotic, okay? And these are actually due to the muscle hypersensitivity, and there are also medications to solve the issue.
Now, when you get a heart attack, or when you think you're having a heart attack, you go into the emergency, a few things happen, okay? They go there, they do an ECG on you, they check you out. They also do a TROP-T. I think doctor can explain that. A TROP-T is to see if a certain enzyme is released into your blood upon a myocardial infarction or a heart attack, little things like that. So if you understand the process of what happens at emergency, maybe that'll shed light on what happens when we go to the hospital. So saying if I have chest pains now, I walk into a hospital, what happens immediately?
All right, when typically a patient who come in with a chest pain to let's say the accident emergency department of any hospital, he'll be triage, So now the doctor will see the patient and get a proper history and to get the so-called the symptom of chest pain, how is the chest pain like, and of course an ECG will be done. The ECG is of utmost importance because it will be able to tell us whether this is a ST elevation myocardial infarction or non-ST elevation myocardial infarction, what we call in a layman's term a true transmural heart attack that affect a big portion of the heart, or just a small heart portion of the small portion of the heart muscle. Now, of course, we will take a blood test, the cardiac enzymes, and of course the highly sensitive troponin T or troponin I. Right. These are very sensitive enzymes.
What's the difference between a trop T and a trop I?
It's about the same actually. Yeah. It's actually a enzyme released by your heart muscle when there's a so-called necrosis or death of it due to inadequate blood supply. It's very sensitive. You'll be able to pick up whether you even suffered a minor heart attack. And once, let's say, if the ECG showed that you have got a ST elevation myocardial infarction, it becomes a very important thing for us, a cardiologist. ST elevation, because you want to bring the patient in a PCR, in a angioplasty equipped hospital with cath lab. You want to bring the patient as soon as possible to the cath lab for primary angioplasty. You want to do an angiogram and you want to find the blockage, and you want to relieve the blockage as soon as possible, because time is muscle. Every minute lost is death
muscle damage.
Muscle damage. You do not want the patient to end up with heart failure.
Right.
Of course, in hospital that don't have a cath lab, they can always thrombolize the patient with medications that actually dilute the blood and try to relieve the obstruction. So, of course, if you are proven to have a heart attack or myocardial infarction, the drugs that the medical will be given in the A&E will be an antiplatelet, aspirin, and of course all the other
clopidogrel, aspirin,
ticagrelor. And pain relief. Remember, a patient that come with a heart attack really have got very severe chest pain. It is out of this. In the description, in their own words, is something they've never felt before, and they feel that they are dying. Okay, they cannot describe to you the feeling. Yeah.
Now, very interestingly, you talk about medication. We just talked about blood thinning medications and all the medications to kind of help you survive or live around heart problems. Now, the other problem is alternative medicine has come to say that whatever that's being given by a doctor or which is given by a doctor is stuff that you can't take long term. And I think there's a lot of studies being done. Of course, the risks are also looked at all times, especially when you're giving out antiplatelet medicine and also giving out cholesterol medication. Yeah, it has its risks, but that risks, have been taken into account. Yeah.
All right. Now, if a patient has suffered coronary heart disease, okay, he or she should remain on an antiplatelet agent for life, lifelong, long term, as well as a statin. A statin is a medication to bring down your cholesterol.
Right. While you're talking about statins, while you're talking about statins, very quickly, a lot of people say now that cardiologists give out statins and also CoQ10 in order to help with the body aches, so on and so forth. Is that true?
Okay, that's a very interesting question. Okay, as you know, maybe in a minority of patients who is taking statin, they develop a muscle ache. Okay, muscle ache is one of the known side effects of taking a statin. But and anecdotally, there are reports that says that if you take coenzyme Q10 along with a statin, it might reduce your chances of getting a muscle ache, or even reduce the painfulness of a muscle ache.
Or fatigue, they say?
Or fatigue. Yeah. I think jury is out there. It's no definite evidence-based medicine for that, but certainly anecdotally, some patients feel that they felt that their muscle ache is less.
It's so interesting that you say this, because I really need to bring this up, and I didn't tell you about this, but we really need to talk about, a lot of people are going and saying that you need to take high doses of vitamin C if you have heart problems. Now let's hear it from the cardiologist. What do you say?
I'm a cardiologist that's evidence-based.
Evidence-based.
I think all doctors should be actually practice evidence-based medicine nowadays. Vitamin C, again, anecdotally, there's no well randomized trial and large trial to actually show that.
You're looking for the double blinds, randomized,
placebo controlled. So I think again, these are all just anecdotal reports and not really proven.
Right. Now, does having CVD increase the possibilities of having a stroke also?
Definitely, because if you got a stroke, can be the main. There are two types of stroke: the ischemic stroke, or the stroke due to blockages of your cerebral circulation, or the hemorrhagic stroke, or bleeding stroke. The majority of the stroke is actually ischemic stroke or due to blockages. The same risk factors that causes blockage to your coronary arteries are the same risk factors that causes blockage to your cerebral circulation. So if you have got coronary heart disease, your chances of having a cerebral vascular accident is increasing.
So if you don't want for this to happen, if you see this little model here, and if you don't want for this to happen, what should we do? Essentially, taking medication and having a proper diet. What would be your advice before we end the segment on cardiovascular disease? What would be the thing you tell people all the time?
I think I tell people
your mantra.
Yeah, I tell them, there's never a age where it's young enough for you to get a medical checkup or a medical consult. Go for regular medical checkup. Okay, know your blood pressure level, know your cholesterol level. Make sure you are not diabetic. All right. Okay, and exercise. You must do exercise and avoid obesity. And if you smoke, please stop smoking.
Okay, now that you mentioned diabetes mellitus for the third time, I need to ask you, what's the world standard now? When are you pre-diabetic and when are you diabetic? Now they say it can be reversed. What are they meaning by reverse? When it's reversed, you can't go back to the way you used to eat, innit?
You see, we know that actually when a person is diagnosed as diabetes, that means his fasting glucose level is more than 7 millimole per liter, or HbA1c of more than 6.5%. The HbA1c is the average sugar of 3 months. These are what we use to define a diabetic nowadays. When we see a patient with diabetes, we know that historically this didn't occur overnight. The pre-diabetic has occurred many years before that. We hope to catch the population before they reaches the diabetic, okay? And we always tell them actually to watch their weight, okay? Know their sugar level. You do not want to reach your HbA1c of more than 6.5% before you see a doctor.
Right.
All right. I think that's why it's so important to get regular medical checkup.
So it's very interesting to note that when you take care of yourself, a few things you have to look at. The first thing is your sugar levels. Always go get your lipids done, which is your cholesterol blood test. It's a very simple blood test. It's only about 30-40 ringgit. If you go anywhere, you can find out. Most labs have it. Do your A1C, that's very important. It shows you your sugar for 3 months. And anything else to add on to that?
I think that's my mantra.
Yeah, that's your mantra.
Yeah, all right. Okay.
So that's all we have on this segment, talking about, of course, the very interesting subject in Malaysia, which is cardiovascular disease. Joining me was Dr. Chee Kian, who's a consultant cardiologist at KPJ Tawakkal KL Specialist Hospital. Doctor, thank you very much. It was a pleasure and an honor having you here. Stay with us. We're going to take a short break. When we come back, we'll bring you more right here on season 3.0 of Medical Today. I'm Jared Ratnam. Hello and welcome back to Medical Today. Jared Ratnam with you in the final segment. In the last season, we did bring you videos. Once again, we're going to start bringing you videos. But in this season, what we're going to talk about is misconceptions and things we do wrong at first aid or in first aid situations. Now, a lot of us mean well, when there's a collision or an accident by the roadside. We want to stop and help at all times. But when we get there, we find out we are either doing the wrong thing or we don't know what to do. Now, there are many ways to help out at a first aid scene. The best thing would be to call 999 first and to get advice. But other than that, if you're wanting to learn more tips about what to do at a scene or things we take for granted or misconceptions about first aid, we've got a fantastic video for you. Let's take a look at a few common mistakes whilst administering first aid. Here is the video. Let's take a look at it.
The mistake is tilting your head back during a nosebleed. This can cause the blood to drain into the back of your throat, which can make you gag or cough, potentially obstructing breathing. Do this instead. Lean forward and apply direct pressure by pinching the bridge of your nose. Keep your head in a neutral position with your chin parallel to the ground. Sit and stay relaxed. There are some situations whereby nosebleed can be caused by an underlying health issue, in which case you need to seek advice from a medical professional.
Well, that was a video for you on common mistakes or things we take for granted or don't know with regards to administering first aid. But remember, at all times, call 999 first. Don't forget, in season 3.0, you'll be getting more of these videos coming your way. In the meantime, let's get to some very, very interesting stuff before we end today's show. This time around, what we're going to do is give out some treatments, and we're giving away a free laser medicine treatment for 3 emails, or the first 3 emails that come in. All you need to do is send me the name of the person who we interviewed with regards to laser on this show. Send us an email with the person's name. All you need to do is send it to ask@medicaltoday.my. That's ask@medicaltoday.my with the interviewee's name. So he spoke about laser. What is his name? If you can send me the name, the first 3 people to send in an email will receive a free laser medicine treatment. Well, just to give you a heads up, next week in episode 2, we'll be talking about fertility, the keys to IVF success, and joining us in the studio then will be Dr. Mohanraj Varudaraju. He's a specialist obstetrician and gynecologist from KPJ Damansara Specialist Hospital, happening right here on episode 2 of Medical Today. On behalf of the team and the crew in the studio, I'm Jared Ratnam signing off. We'll be back next week with more for you in episode 2 of Medical Today. Have a great day ahead.